Hello, and welcome to the Medicaid and CHIP Payment and Access Commission's Medicaid 101 series. Today we'll be talking about home and community-based services. But first, a little bit about the Medicaid and CHIP Payment and Access Commission, or MACPAC. MACPAC is a nonpartisan legislative branch agency that provides policy and data analysis and makes recommendations to Congress, the Secretary of the U.S. Department of Health and Human Services, and the states on a wide array of issues affecting Medicaid and the State Children's Health Insurance Program, or CHIP. MACPAC conducts policy research and analysis that is fact-driven and evidence-based. For more information, visit macpac.gov. This presentation will focus on home and community-based services, or HCBS. This presentation will include background information on the delivery of HCBS, followed by the Medicaid authorities for the provision of HCBS, HCBS access challenges, and finally we have included a number of MACPAC resources for your reference. During this presentation, we will be referring to acronyms that describe individuals' functionality. These definitions serve as the basis for determining access to HCBS services. Examples of activities of daily living, or ADLs, include bathing, dressing, and toileting. For instrumental activities of daily living, or IADLs, this includes household chores and grocery shopping. Medicaid policies to determine eligibility for long-term services and supports, or LTSS, focus on finances, like income and assets, and measures of functional status, rather than the existence of a specific clinical condition. In other words, people become eligible because they have low incomes and assets and meet specific state-based thresholds for clinical and functional impairment. Eligibility determinations for LTSS generally focus on measures of functional status, referred to as level of care, or LOC criteria. To make these determinations, states use functional assessment tools, collecting information on an applicant's health conditions and functional needs. These tools can also be used to develop a care plan of specific services that an individual will receive upon being determined eligible for coverage. Under the Affordable Care Act, there are certain populations who are exempt from the MAGI income counting rules. This includes individuals who are 65 and older, blind, or disabled. For the MAGI population, asset tests are not used to determine financial eligibility for Medicaid, unlike the non-MAGI population, where assets are taken into account. There are multiple eligibility pathways for Medicaid LTSS. Certain LTSS are available to any enrollee who meets state-determined medical necessity and LOC criteria. Other services, including those provided through waivers and certain state plan options, may be limited to specified populations. Although states are generally required to cover beneficiaries who receive Supplemental Security Income, or SSI, all states also cover individuals through one or more optional pathways, as seen here. States vary in terms of the pathways available to beneficiaries. Pathways differ by income and asset limits. For example, through the poverty-related pathway, states can cover individuals with incomes up to 100% of the federal poverty level, while the special income level pathway allows states to cover eligible individuals who meet institutional level of care with incomes up to roughly 222% of the federal poverty level. Until 1981, with the enactment of Section 1915C Waiver Authority to provide HCBS to beneficiaries who would otherwise receive institutional care, there was no standard vehicle for covering care in the community. The intentional investment in community-based care, as opposed to institutional settings for people with long-term services and supports needs, over the last 2 decades was partly driven in response to both the Americans with Disabilities Act of 1990, which required states to provide services to individuals with disabilities in the most integrated setting, as well as the 1999 Olmstead versus LC case. Over time, legislative and regulatory changes have expanded Medicaid support for HCBS. Increasing investment in HCBS relative to institutional care has been a federal and state goal for decades. Medicaid programs have spent more on HCBS than institutional services since fiscal year 2013, and this trend has continued over the years. In 2019, HCBS expenditures as a percentage of total Medicaid LTSS expenditures was 58.6%. In Medicaid, HCBS is an optional benefit for states, and institutional care is mandatory. Data from fiscal year 2020 that reflect per-person spending by target population among Section 1915C waivers demonstrate the highest spending is for the population of individuals with intellectual disabilities and developmental disabilities, at $48,900 per person on average. To address state variation in names of services and to make it easier to report on HCBS use and spending, in 2014, researchers from Truven Health and Mathematica released an HCBS taxonomy, a uniform classification system that includes 18 categories and 60 specific services associated with a range of categories. In thinking about the types of HCBS, states reported that in 2012, home-based services were most commonly used, with 47% of all people who used HCBS having claims for home-based services, which include services such as a home health aide and personal care. Another 41% of people who used HCBS had waiver claims for case management services. Round-the-clock services, such as group living, shared living, in-home habilitation, home-based services, and day services comprised 77% of total Medicaid fee-for-service expenditures for waiver users in 2012. Congress has amended the Medicaid statute over time to offer states multiple flexibilities to provide HCBS. States can select options like Medicaid state plan authorities, waivers, and demonstration authority. In many states, this array of options has created complex systems for states to maintain and beneficiaries to navigate. Medicaid HCBS are designed to allow people with long-term services and supports needs to live in their homes or a home-like setting in the community. They encompass a wide range of services, such as personal care services provided in a community setting, supported employment, non-medical transportation, and home-delivered meals. While states often use multiple different Medicaid authorities to administer HCBS programs, Section 1915C waivers are the most common. HCBS provided via state plan authority includes Sections 1915I, 1915J, and 1915K. A limited number of states use the state plan authority option to offer HCBS, given state interest in budget predictability. Under waivers, as will be discussed shortly, states have the authority to limit the number of people who use HCBS, which allows them to better predict spending and keep it within available state dollars. There are different considerations a state takes into account when deciding which Medicaid authority, either a state plan or waiver, to use for the provision of HCBS. For example, will the HCBS authority the state selects require statewide coverage, use of waiting lists, or budget neutrality? For HCBS benefits authorized via state plans, statewide coverage is a requirement, with one exception being Section 1915J, where states are not required to offer it statewide. Similarly, under 1915J, waitlists are permitted. Other state plan authorities are provided to all eligible beneficiaries without limiting or capping the number of people who could be eligible. Separate from Medicaid HCBS authorities are state plan benefits that include HCBS. For example, personal care services are optional services authorized via Section 1905A and are available in 37 states. Although state plan options are less common than waivers in the provision of HCBS, the Section 1915I state plan authority is available in 14 states and the District of Columbia. It was amended back in 2014 as part of the Affordable Care Act. This authority provides states with the opportunity to provide preventive services via HCBS prior to a beneficiary meeting an institutional level of care. Under this authority, states can waive certain requirements such as comparability, meaning that states can target services to specific populations or persons with particular health conditions under the authority, and income rules, meaning that states are permitted to exclude the spouse's income in order to keep individuals eligible for Medicaid and enrolled in HCBS without requiring institutionalization. Under this authority, however, states are not permitted to restrict the number of eligible individuals or establish a wait list, and services have to be offered statewide. Next, we have 1915J. Through this authority, beneficiaries can hire and direct their own personal assistance services, and in some instances, beneficiaries can manage their own budget as well. Given that self-direction is offered through other Medicaid authorities, this authority is not frequently implemented by states. Under this authority, states are not required to offer this service statewide and may even waive the comparability requirement by only targeting persons receiving 1915C waiver services, for example. Finally, we have 1915K, which is also known as the Community First Choice or CFC option, and is available in 9 states. It was established as a result of the Affordable Care Act. Eligible beneficiaries must meet an institutional level of care. Under the CFC option, individuals receive personal attendant services and supports. For all states who opt for a 1915K, they receive an enhanced federal medical assistance percentage, or FMAP, of 6 additional percentage points for CFC services and supports. Under this option, there are no restrictions on the number of individuals served, nor is a waiting list permitted. States must also adhere to the state wideness requirement. However, under this authority, states can waive the income rule. Now we will switch gears and discuss waiver and demonstration authority, focusing in on a 1915C waiver and an 1115 Research and Demonstration Project waiver, which is authorized by the Secretary of the Department of Health and Human Services. These authorities allow states to forego a number of Medicaid requirements, as we will review on the coming slides. Section 1915C waivers are the most common Medicaid authority that states use to administer HCBS, with 47 states and the District of Columbia offering at least one 1915C waiver to beneficiaries. States may operate several 1915C waivers, targeting HCBS to particular LTSS populations. Services offered via these HCBS programs range, but may include personal care services, adult day health, respite, among others. Beneficiaries eligible for HCBS under a 1915C waiver must meet an institutional level of care, be a member of the waiver target group, meet financial eligibility criteria, and have the need for a minimum of one waiver service to function in the community. For 1915C waivers, requirements that may be waived include state wideness, comparability, and income rules. And enrollment caps and waitlists are permitted. An analysis of waivers and associated waiting lists conducted by MACPAC in 2020 found that waiting lists varied in size, and waiting list times differed by states and even within states by type of waiver. Based on our interviews with selected states, wait times varied widely from less than 1 year to multi-year in some cases. 1915C waivers are initially approved for 3 to 5 years, with a renewal option of 5 years. Section 1915C waivers have a cost neutrality requirement, meaning that states must provide assurances that the average per capita expenditures for covered HCBS services will not exceed 100% of the expenditures that would have been made for the level of care provided in an institution. Currently, 14 states cover HCBS via Section 1115 Demonstration Authority. This type of authority is not specific to HCBS, however, it's a broad authority that permits states to test novel delivery models. For 1115 Demonstration Authority, the Secretary may waive several requirements under Section 1902 of the Social Security Act. Waivers are initially approved for 5 years with an option to renew. They must also be budget neutral, meaning that federal spending under the demonstration cannot exceed what it would have been in the absence of the demonstration. In its June 2023 report to Congress on Medicaid and CHIP, the Commission discussed a new Medicaid HCBS access monitoring framework with 4 key domains of access. Provider availability and accessibility looks to capture things such as potential access to providers and services, and worker availability. The use of services domain of the access framework measures realized access by examining use of services. Next, beneficiary perceptions and experiences of care is focused on barriers to accessing care, experiences with care, and beneficiaries' knowledge and understanding of available benefits. Finally, administrative complexity examines state administrative burden in managing multiple HCBS programs, often under different waivers or state plan options, implications of system complexity on beneficiaries, as well as state capacity and resources. MACPAC's findings, which are supported by the literature, point to challenges in each of the 4 access domains. These include shortages of the HCBS direct care workforce, variation in use and spending of support services among LTSS users, confusion among beneficiaries regarding available HCBS options and how to access them, and limited state capacity to navigate the range of HCBS programs. We encourage you to engage with our previous LTSS work, as seen on this slide. Thank you for listening to MACPAC's 101 presentation on home and community-based services.